evening. On behalf of the NYU Myers Alumni Association, I would like to welcome you to the program this evening. My name is Peter Stoffen, and I serve on the Alumni Association Board and currently am the Magnet Program Director at New York Presbyterian Morgan Stanley Children's Hospital. It's been over 40 years since the nation's first reported cases of AIDS. More than 700,000 people in the United States have died of the disease since then. And though medical advancements have drastically changed the prognosis for HIV/AIDS patients, there remains to this day no cure. The National HIV Strategy has a goal of ending the epidemic in the United States by 2030. Tonight, we are joined by Dr. Jeffrey Kwong, who is going to share the current state of HIV treatment and prevention, the role of nurses in the delivery of care, and challenges facing the growing population of persons aging with HIV. Dr. Jeffrey Kwong is an adult gerontology primary care nurse practitioner and professor in the Division of Advanced Nursing Practice at Rutgers University. His work in the field of HIV treatment and prevention spans more than 25 years. In addition to his academic work, he is the co-medical director of the HIV and Aging Initiative for the American Academy of HIV Medicine, co-director of the HIV Infectious Disease Specialty Group of the American Association of Nurse Practitioners, and serves as a member of Mount Sinai's HIV Project ECHO core faculty. Dr. Kwong is a fellow of the American Association of Nurse Practitioners and the American Academy of Nursing. Welcome once again, and I will now turn the program over to Dr. Kwong.
Well, thank you very much, Dr. Stoffen, and thank you very much to all of you and to the Alumni Association for inviting me to present this evening. I'm just going to go ahead and get my slides here. Can everybody see my screen? Yes? Okay, perfect. Well, thank you again for joining me. And it is a very informal presentation. Please do type in your questions in the chat box, and I'll hopefully get a chance to answer them before the conclusion of this presentation. These are the objectives for this evening. They're listed here, and I have no disclosures. So to get things started, I thought when we think about HIV and we think about the epidemic, I think many of us really think about these images that are shown here. And it's really kind of amazing to me to think that it's been 42 years this year when, the first cases of what was then an unknown condition was first recognized in a group of young gay bisexual men in Los Angeles. And that really sort of harkened or began what has now become a global pandemic. It has been a global pandemic for the last 42 years, but it's also very exciting and amazing to think that in 2023, we now have options for preventing HIV as technology has advanced. There are now medications that are available, that are injectable, that you can just take every 2 months to help prevent new infections from occurring. And just recently, in December of 2022, we had our first long-acting injectable that is administered every 6 months. And this really is such a dramatic change in evolution that has occurred, and it continues to evolve. And I'll talk about all of these things during the presentation. What also I think is interesting, if you haven't been following HIV as closely as I have over the last 20 years or so, I think this is something that really is really a true testament or statement of where we have come. And that is over the last decade or so, when we think about the epidemiologic pattern and the causes of morbidity and mortality, really since 2010 or so, causes of mortality in persons living with HIV are really now associated with non-HIV related conditions. So conditions such as cardiovascular disease, cancer, renal disease, are now surpassing those of opportunistic infections in what have traditionally been known as HIV-associated conditions. And that is due to really the advancements in technology and treatment that have evolved to effectively treat and manage persons living with HIV. But as a result of that, what we're seeing is really a shift in the population and the demographics. And so this is just data that shows the distribution of persons in the US living with HIV. And you can see that with regards to people 50 years or over, in this data presented, they account for more than 50% of individuals living with HIV. And that number is expected to increase significantly, which has implications for healthcare providers, the healthcare system, and nurses. And I'll talk a little bit more about that as we go through this presentation. But also in 2023, when we think about the global epidemic or pandemic, it still amazes me that in 2021, there were still 1.5 million new infections occurring globally. That boils down to about 2 to 3 new HIV infections every minute worldwide. And in the US, although we've had great success with treatment and prevention, there still are about 30,000 new infections occurring every year, which still boils down to about 3 new infections every 60 minutes. So, when we think about, yes, HIV, it's not an issue anymore. When you look at these numbers and you think about the statistics, it's still an issue, and we still have a lot of work to do as a community, both domestically and globally. I know Peter mentioned and alluded to the National HIV Plan or strategy. And I don't know how many of you are familiar with this, but this is something that has been developed and has been published through the presidential office. And this sort of sets a blueprint or goal for the country in terms of strategies and initiatives that the health system and that the government can really focus on in terms of where they can intervene with regards to the epidemic. And it has several different pillars, but the overriding theme is or the goal is to have a 75% reduction in new HIV infections by 2025 and a 90% reduction by 2030, which is a very ambitious goal to think about where we need to be in the next decade or so. Embedded within the National HIV Strategy are really these 4 pillars, which are also known as the End the HIV Epidemic sort of strategies. And these strategies are to diagnose all people with HIV as early as possible, to treat individuals as quickly and effectively to get what's called viral suppression, or to get their viral load or the amount of HIV that's circulating in their blood to less than detectable levels on blood tests, to prevent new infections with the use of pre-exposure prophylaxis and other interventions such as syringe services programs, and then also from a public health perspective to respond quickly to potential outbreaks in order to get prevention services to people who need and treatment services to people who need them. If you look at the sort of trends where we are and that goal of reducing new infections by 75% and by 90%, you can see we really do have a long way to go. With the current estimates being about 30,000 new infections, the goal by 2030 is to reduce that number to 3,000. So that will take the effort of not just one person, but really a whole village, a global village, if you will, to really reduce the number of infections. And it requires public health professionals, frontline professionals, advanced practice providers, and really the interprofessional team to really get these numbers down. Now, when we think about HIV, really this is an example of a condition or a disease state that really exemplifies or demonstrates the power of health disparities and health inequities in our country here in the US. And you can see here, when we think about new infections and communities that are bearing the brunt of new infections, you can see that really communities of color, specifically here in this graphic, you can see both 2015 and 2019, different populations and different subpopulations by race and ethnicity, that compared to whites, the rates of new HIV infections is 8 times higher among those who identify as Black or African American, and 4 times higher among Latino and Hispanic people. So, when we think about health equity and health disparities, HIV is one clear example of that. And more specifically, if we look at other populations, so this is data from the CDC that looks at individuals of transgender experience, specifically individuals of color of transgender experience. And you can see here, 62% of Black and transgender women have HIV, and 35% of Hispanic or Latina transgender women are living with HIV as well, compared to 17% of white transgender women. So you can see just the magnitude of differences within different populations in our country. Now, the US has its goal of the National HIV Strategy. New York has our own and the epidemic metrics, and you can find them on the ETE dashboard. And this is just a screenshot showing how we are doing and how we've done over the last 2 years. So you can see here with regards to increasing the number of individuals receiving or using PrEP or pre-exposure prophylaxis, the goal is to get to 65,000. The most recent estimate's about 44,000. In terms of reducing the number of new infections, the goal is to be around 1,500. We're about 2,100. And with regards to getting people to have virologic suppression, the goal is to be about 85. We're at 78%. And so here within the state of New York, which out of all the states in the US, we are one of the leaders in terms of HIV prevention and treatment. We still have a long ways to go as well. Now, for those of you who aren't familiar with this graphic, I'll just orient you to this a little bit. This is what has been known as the care continuum or the care cascade. And it really looks at different levels of the sort of the continuum of HIV care. And so when we think of the very first pillar, which is making sure that people who are living with HIV are tested and know their status, it's estimated that only about 87% of those individuals with HIV have been tested and know that they are living with a diagnosis of HIV. In terms of receiving care, you can see that of those 87% of people who are diagnosed, 60% receive care. Of those, 50% are retained in care after a year, and of those, 57% receive or are able to achieve virologic suppression. So you can see that the biggest drop-off really occurs between diagnosis and receiving care. And this is something that we're really trying to focus on in terms of balancing out these numbers, and to get people to virologic suppression, we have to make sure that they're engaged and retained in care. And there are so many factors that go into that. And I'll try to go into some of those in this presentation. But when we think about virologic suppression and we think about disparities as well, this is also data from the CDC that looks at overall virologic suppression in 2020 among different groups based on race and ethnicity. And you can see the overall percentage, about 64.6% have achieved virologic suppression. But again, there are differences with communities of color not achieving as full suppression as those who identify as white. So again, some disparities which we'll talk about again in greater detail. Now, when we think about HIV testing, so I'm going to talk a little bit now, sort of shifting gears, about the importance of testing. This has been a recommendation that's endorsed both by the Centers for Disease Control, but also by the U.S. Preventative Services Task Force. And for those of you who are familiar with the USPSTF ratings, testing is given a grade A recommendation, which is the highest level of recommendation based on the evidence. And when we think about testing, and I want you to think about the last time that you were at your healthcare provider, if you were offered an HIV test. And you would think that this is part of the guidelines. This has been part of our culture and part of our society for the last 42 years. You would think that people would be offered HIV testing. It is it is a recommendation that is endorsed. However, in fact, the data is quite the opposite. We found, according to this data here through the CDC, that 7 out of 10 patients who are at risk for HIV were not tested when they saw a primary care provider during that period. And when we think about, where can nurses play a role, testing and advocating for testing is key and essential, and it's something that we can do as nurses. And when we think about what are the ramifications of people not necessarily knowing their HIV status and or people who are not engaged in care, you can see this is data from 2016. And I'm just going to sort of walk you through these columns, just primarily the top 2 rows, which is that in 2016, about 15% of people did not know that they had HIV. 23% knew that they had HIV, but were not in HIV care or not in primary care. Of those individuals, they were responsible for about 80% of new infections in 2016. So when we think about the importance of testing, the importance of treatment, the biggest reason you can see here is really that it's in that pocket where we're seeing the number of new infections and new transmissions occurring. And so by getting people tested and getting people in treatment and getting them in care, we could help reduce the number of new infections occurring. I'm going to change gears here and talk a little bit about treatment. Now, in the world of HIV, and when we think about HIV treatment, really the treatment paradigm and our thoughts about treatment have transitioned, and it's really this pendulum that goes back and forth. If you think back to the early 80s, when there were really no treatments available, the only agent that was available was AZT or zidovudine therapy. People were not doing very well. And then around 1995 or 1996, a new class of drugs called protease inhibitors became available. And that was the drug, that class of drugs really shifted the face of the epidemic. And people began, doing really well. We were able to get people virologically controlled, and people were no longer they were getting out of the hospital, they're going back to work, they were revitalized. And so then the mantra became hit early, hit hard, meaning, as soon as somebody's diagnosed, give them the strongest drugs that we have as soon as possible, hit early, hit hard. Well, a few years passed and we started seeing some complications that we weren't quite expecting in terms of metabolic issues, in terms of conditions called lipodystrophy or lipoatrophy, where people had morphologic changes that were permanent and that were as a result of some of the toxicities of some of the medications that we were providing. And so then we pulled back and we did sort of the wait and watch phenomena for a while, where we're like, well, we won't treat you until you really need it. Like, well, we have the treatment, but we're going to wait because we want to just, we want to spare people from the side effects. And then we now have treatment that is so effective with fairly minimal side effects overall. And we're really recognizing the impact and the benefit of early treatment. And now we've jumped back and we've swung the other way again to really rapid treatment. And as soon as somebody is diagnosed, the day that they're diagnosed, the gold standard is to start them on treatment the same day. And that really is a shift for people who've been working in the field of HIV for a long time, where we used to have to wait for a resistance test. We had to make sure that people could deal and understand and cope with their diagnosis before we started them on treatment, because we had very few treatments available and we wanted to make sure that people were ready to start treatment. And so we would wait sometimes weeks, sometimes months before we would start. But now sort of our thinking has changed, and with the availability of drugs that are so well tolerated, we use the idea of sort of the analogy of as if somebody had a UTI or some other infection like bronchitis or pneumonia, right? If you diagnose somebody with a UTI or bronchitis or pneumonia, you don't wait several weeks or months to make sure that they understand their diagnosis, that they can take their medications. You treat them for their infection. And so that has become sort of the mindset. When we think about HIV as an infectious disease, we need to treat it as we do other infections. And so really now it is the gold standard. If somebody's diagnosed, you try to start them on treatment on the same day if possible. And really, that's thanks to the different options that are available. And so if you think about the different phases of HIV treatment over the decades, we had what was called sort of the pre-HAART era, and HAART stands for highly active antiretroviral therapy. That would be sort of 1981 through 1995. Then we had the early HAART era, which is probably 1995 to the early 2000s or mid 2000s, where we had good and potent drugs. And now we're in the era of really modern, streamlined therapy where we're looking at new options that are one pill a day or even long-acting injectables. And I'll talk more about that very shortly. We have over 48 different FDA-approved options. And what's really fascinating is this whole concept of single tablet regimens. And for anybody on this call who may have recalled, even in the mid 1990s where people had to take a handful of pills at a time, there are 11 options for people to take one pill once a day, meaning one pill is a combined multi-drug regimen, multi-class regimen, and you can take them one pill once a day to treat and control and manage HIV. Also exciting is we now have what are called long-acting antivirals. So these are agents that can be administered for long periods of time, as short as every 2 weeks for some, to now, again, every 6 months for the newest agent on the block, which is lenacapavir, which is a capsid inhibitor. Now, both, I will say out of full disclosure, lenacapavir and ibalizumab, which are the last two items on this chart, are really for people who are not doing well on their current therapy and who cannot take or who are not well controlled on other options. They have to be administered with other options. But there is an option, the very first one on this row here, cabotegravir and rilpivirine, which is for people who are doing well on treatment and they transition. And this option is available every 4 to 8 weeks. You can administer it and they don't have to take any other pills other than that injection for their treatment. And so what are the benefits of this new class of drugs when we think about long-acting agents? Really, it helps reduce dosing frequency. It reduces pill fatigue for individuals. It has better bioavailability. It helps reduce the stigma of HIV. And I'm going to talk a little bit about stigma as well. But when we think about, somebody living or finding HIV medications in someone's house or, carrying it when they travel with somebody, that has a lot of stigma for people if they have not disclosed their status to others. And so long-acting agents, one way to avoid having to take a pill every day, right? However, with every advantage come disadvantages. And some of those disadvantages include just right now, we're trying to figure out both from an insurance perspective, how to get the medications, because that's always a challenge. People have to come to clinic about every 8 weeks or every 4 weeks. So it's very regimented in terms of that. But, when we think about where we're going and some of the other things, some people, the benefits do outweigh the disadvantages. The other thing in terms of evolution of our epidemic, when we think about HIV, I think many people really think about things like T cell counts and viral loads. And, it used to be, well, what's your T cell count? What's your T cell count? Because T cells are the cells that are the target cells for HIV. And as people's T cells diminish, they become more susceptible to opportunistic infections. And so we used to monitor them very frequently, every 3 months or so. However, given our understanding of the infection and the importance of virologic control, the significance of that, they've changed the guidelines of the recommendations on how often we need to check and monitor. T cells or CD4 cells. So the current guidelines say that after 2 years of being on stable therapy, for people, if their CD4 count is below 300, you only need to check it every 6 months or so. And if their CD4 count is above 500, which is not too uncommon, you don't even need to check T cells anymore as part of HIV management. However, viral load management or monitoring is still important. Again, we don't have to do it as frequently as we did before, but now we can do it about every 6 months for people who are doing very well. And so that, I think, again, speaks to the greatness of the drugs that we have available. The title of this talk is The Evolution of an Epidemic. And, I also think this is an evolution of providers and our role as providers. So when I think about HIV and I think about the people who were working in the field of HIV, you can sort of think of it as this really transformation. So at the very beginning of the epidemic in the 80s, when people, again, were not doing well, the focus was really on hospice, palliative care. Mostly infectious disease providers were managing persons living with HIV. Then when people started doing well and they weren't in hospice or palliative care, and they were dealing with things like high blood pressure and diabetes and high cholesterol, then the shift or the type of provider or the skill set of the provider really had to change. And people went from being infectious disease specialists to having to broaden their knowledge to being primary care providers. And sort of on the opposite end, primary care providers who used to think, oh, HIV that's an infectious disease issue. We're now having to see and manage patients in their primary care practice and really had to learn how to sort of manage both of these. And now, as the population ages into older adulthood, really we need to become geriatric specialists. And when we think about the field of medicine, geriatrics is its own specialty. When we think about nurse practitioner training, adult gerontology is a specialty in and of itself. And there are still geriatric only NPs as well. And so when we think about where we're going, both as a community of persons living with HIV, but also sort of the broader community as baby boomers age into older adulthood, there is going to be this significant need for geriatric providers who are also skilled HIV clinicians and vice versa. Because in 2030, they estimate that that nearly 70% of people living with HIV will be 50 years or older. And when we think about aging with HIV, it's not just that people are living longer with HIV, but when we think about the comorbidities and the other chronic conditions like heart disease, diabetes, kidney disease, neurocognitive disease, we not only see these in greater proportion or in greater frequency in persons living with HIV, but we also see them occurring a little earlier in persons living with HIV than those without HIV. So there is definitely differences in terms of caring for persons who are living with HIV, who are aging in terms of the frequency and the different types of comorbidity. So you can see here on the left is a cohort of persons living with HIV based on age, and on the right-hand side, similar cohort with persons without HIV. And the dark bars represent the number of comorbidities. So just look at the dark blue bars. You can see there are higher numbers of blue bars in the persons living with HIV compared to those without. Similarly, when we think about conditions such as frailty is a geriatric syndrome, if you will, right? It's multiple conditions that we see in older adults. There's data, and I won't go into too much detail here, but I'll just kind of summarize the information for you. But what we see is both frailty and pre-frailty occurring at greater proportions in persons living with HIV, and also occurring at much younger ages than we would anticipate than in persons without HIV. And if you look on the image on the right, these are just the different components of frailty. These are based on what's called the Fried frailty type or phenotype, which looks at things like physical activity, weakness, slowness, etc. And you can see persons with HIV in the sort of magenta colored compared to those without HIV, higher proportions and statistically higher proportions on each of these conditions. What about things like fracture? We know that older adults, one of the biggest causes of mortality is hip fractures and falls. So when we look at persons with HIV compared to those without, also by gender differences here, this is from the Partners Healthcare System out of Boston, you can see persons with HIV depicted in the orange lines, the rates of fracture are much higher than compared to those without HIV. And that, again, our understanding of all of this is that it's multifactorial. Similarly, with cardiovascular disease, higher rates of cardiovascular events in persons with HIV, this time in gray, compared to those without HIV, displayed here in orange. When we think about cardiovascular risk and we think about management of disease, we use what we have available, right, to estimate would somebody benefit from, say, a statin or some sort of preventive intervention for atherosclerotic cardiovascular disease. So we have tools like the Framingham Risk Score, or we also have something called the ACC-AHA CVD Risk Calculator, which some of you may be familiar with, which is the American College of Cardiology, American Heart Association Risk Score, where you can sort of plug in numbers and it gives a prediction. If somebody is at higher risk for a cardiovascular event, they may benefit from a statin. Well, what the researchers did in Boston in this study that they published here is they looked at individuals living with HIV and they plugged in the numbers into both the Framingham Risk Score and the ACH-AHA Risk Calculator. And they determined, you can see in the gray bar, the prediction of the cardiovascular events based on the calculator. But what they then did was they plotted out the actual number of cardiovascular events that occurred, and those are depicted in blue. And you can see that the calculators underpredicted the actual events of cardiovascular events, which means that when we think about sort of evidence-based tools and when we think about what we have to treat and manage and care for older adults living with HIV and multiple comorbidities, in fact, the tools that we have may be insufficient or may not really truly predict, or in fact, may be under predicting risk. And so we have to sort of, as clinicians, as HIV providers, really sort of take that into account when we're managing our patients. And again, as I mentioned, this is really a multifactorial issue. And, full understanding of the breadth and depth of these interactions is really still unfolding. We know that even people who are doing well on HIV treatment and have an undetectable viral load, there is this potential for chronic immune activation and inflammation. And we know that inflammation can precipitate or potentially accelerate conditions such as aging. And all of these things play a role together, as well as some of the side effects of some of the HIV medications or the antivirals that people are taking and using in order to do well. So one of my areas is geriatrics and HIV and aging, and one of the biggest issues in aging is polypharmacy. And when we think about the impact of polypharmacy, we know that polypharmacy has and is associated with non-adherence, with drug-drug interactions, and higher rates of geriatric syndromes. There was a study done, this is a very small study, but it was through, I believe it was the VA. They looked at persons with HIV over 50, and they found that the mean number of medications that people were about 14.2 different medications. 35% of the population were taking more than 16 medications a day, and 63% had one or more inappropriate prescriptions, meaning prescriptions that would be considered dangerous or hazardous to somebody who is older. And this whole concept of polypharmacy, you don't really necessarily think about so much, right? When you think, wow, HIV treatment, just one pill a day, that's great. Yes, that's one pill once a day. But then they also take their metformin twice a day. They also take their amlodipine and their Norvasc and their amlodipine hydrochlorothiazide and their valsartan, as well as their statin, as well as their tamsulosin for BPH, as well as their gabapentin for neuropathy, as well as their sertraline for depression. And when we think about, yes, it's one pill once a day, but when we put it in the context of multiple comorbidities and management of other conditions, it really is an issue and will be an issue as we move forward. And that's why things such as long-acting injectables or long-acting treatment is really exciting for us, because we can potentially eliminate or minimize some of those treatments as well. Now, we said stigma was a big factor and plays a role in terms of this epidemic. And stigma is a very powerful issue that affects both access to treatment as well as motivation to receive treatment from a provider. And there have been numerous studies and numerous campaigns, and this the CDC actually has a whole Stop HIV Stigma campaign. As part of the national HIV strategy, they actually have incorporated one of the pillars focused on stigma. I'm just going to read you, this is directly from the National HIV Strategy, that says that it's important to ensure that healthcare professionals and frontline staff complete education and training on stigma, discrimination, and unrecognized bias towards populations with or who experience risk for HIV, including LGBTQI people, immigrants, people who use drugs, and people involved in sex work. And when we think about stigma, remember that individuals are not living just with HIV stigma, but there's also, or they could be experiencing transphobia, homophobia, immigration concerns, people who may have experienced incarceration, people who may be struggling or have substance use or abuse backgrounds or histories, people who are aging who experience ageism, and those living with mental health conditions or disorders. Really, all of these things can impact that care continuum or that care cascade. And so, when you look back at that continuum that I showed you at the very beginning, and you think, wow, we have all the tools, we have all the treatment, they're very highly effective. You told me that these medications are really great, yet only 67% of people are getting to virologic suppression. We know that people are falling out of care, not getting care. And part of it is because of many of these issues that are listed here. And one thing that you can do as a healthcare provider, as a nurse, is to make sure that when you're providing care for persons living with HIV, that you use a trauma-informed approach, or that your organization uses a trauma-informed approach, and you can advocate for that within your hospital setting, within your clinic setting, just to make sure that you recognize and that you meet patients where they are, and that you incorporate and you recognize all of these issues that are behind the person that's sitting in front of you. And it's not just the 23-year-old who's here for their follow-up, or the 56-year-old with hypertension and HIV who's here to get their blood work done, but really to think about all of the things that come with them, and to make sure that you address and be sensitive to all of them. One of the things that is being thought of in terms of sort of paradigm shifts is this whole concept of status neutral. And I think this is a great model or great concept. So, when we think about people who get HIV testing, Now, we know we need to make improvements in that front. But when we think about people who come in and get tested, so if somebody's tested and they're living with HIV, the concept is to really put them on the treatment pathway and get them into care and on treatment. But for people who test negative, you want to think about putting them into the prevention pathway. And so hence we get either the positive or negative test, but really you put them into this, what has now been termed the status neutral continuum. Now, I talked about treatment. I'm going to talk now a little bit about prevention. And when we think about prevention, really there are multiple options available. There's something called PrEP or pre-exposure prophylaxis. There are things such as syringe exchange programs for people who may use persons who inject drugs. There is non-occupational post-exposure prophylaxis or NPEP. And then there's something called TASP, which is treatment as prevention, where people living with HIV, we're able to get them to undetectable levels. So really, all of these are part of the prevention continuum. And when we think about PrEP, going back to the USPSTF guidelines, they currently say that PrEP should be, that all patients should be informed about PrEP, and that we should offer PrEP to anybody who asks for it. And that is, again, a grade A recommendation by the USPSTF. But there are other indications that are listed here in terms of who may benefit from PrEP, including people who may have had a recent or current STI diagnosis, anybody who reports inconsistent condom or barrier methods, or anybody who may report using or sharing injection drug using equipment as well. And in terms of PrEP or pre-exposure prophylaxis, we have 3 options currently FDA approved in this era, which is 2 oral options and 1 injectable option that's administered every 2 months to individuals who are eligible. Now, similar to HIV treatment in terms of side effects and adverse events, we know that there are metabolic changes that can occur with either of the 2 options for oral pre-exposure prophylaxis, including effects on cholesterol, weight, renal function, and bone mineral density. But those are things that we monitor. And again, we have to think about risks and benefits overall. In terms of adolescents, we know that in fact, yes, the guidelines for USPSTF say to start testing at 15. New York State, the guidelines say to start at age 13. And adolescents can access both PrEP and STI services without the need for parental consent in New York. There is limited data on the use of the injectable medication in adolescents, but nonetheless, adolescents could and may benefit from PrEP as well. In terms of other populations and other categories, in terms of PrEP and pregnancy, PrEP is an option for individuals who are trying to conceive if they have a partner living with HIV who may not be fully virologically controlled on their treatment. But nonetheless, if it's an option for people, if people do use this for or during conception, they do recommend reporting and supplying the information to what's called the antiretroviral pregnancy registry, because we are still trying to collect additional information. Now, when we think about PrEP and we think about disparities, only about 25% of those who are eligible for PrEP were actually prescribed PrEP in 2020. And here again, when we think about differences in terms of coverage, again, overall about 25% eligible for PrEP were prescribed, but it was not equal according to different race and ethnicity breakdowns. Again, Black, African American, 9% of those eligible were actually receiving PrEP. For those who are Hispanic or Latino, 16%, those who are white, 66%. So when we think about prevention, we still need to make sure that we are looking at all the communities that would benefit. In terms of persons who inject drugs, I'm just going to call your attention to the top of the pyramid here, or the bottom of the pyramid, which is that of those who are eligible, only 1% of persons who inject drugs were receiving What about people who are in serodifferent couples or situations where one person is living with HIV and one person is living without HIV, and what is the risk in terms of sexual transmission. Well, in terms of PrEP and prevention, again, I talked about that whole concept of TASP, or treatment as prevention. And we do know that for people who are living with HIV, who are virologically suppressed or controlled on the regimen, there is effectively no risk in terms of sexual transmission. This is, you probably may have heard of the term U equals U, or undetectable equals untransmittable, again, endorsed by the NIH, and has been well supported in numerous studies. Now, you saw the differences in terms of PrEP uptake and sort of the disparities there. But what are some of the barriers to PrEP uptake? Here's an intervention. It's readily available. Why aren't people using it? Well, you can think of it as, I put here 2 levels of barriers, but really there's another one which are really system level barriers. But when we think about patient level barriers, people just don't know about this option as an availability. There's, again, stigma associated with it, concerns about insurance or adherence or side effects. From the provider standpoint, providers not aware that it's available, or primary care providers thinking, oh, that's something that the infectious disease HIV people do. I don't really do that. But I want to let you know that really PrEP is a primary care issue, or it falls right smack dab in the realm of primary care, because remember, PrEP is prevention. It's preventive health. It's preventive medicine, really. And so nonetheless, there are still provider barriers where people don't want to talk about sex. They don't want to talk about substance use risk. They don't want to really open that door because of many different issues. But I'm going to challenge you to be an advocate for that as well. Now, looking ahead, it's a very, very exciting time in the field of HIV. We have new treatment classes and drugs. They're broadly neutralizing antibodies. There's people, again, very small number of cases, but we just had the 5th official case reported just last month at one of the big HIV meetings called CROI, where somebody who had undergone stem cell transplant, again, 4 years later, no evidence of HIV, and we use the word cure very lightly here, but again, I think it's exciting that we're on the cusp potentially of that. There are new treatment delivery systems, one still under investigation, but there are ones that are implantable, that are much like long-acting contraceptives like Implanon, where people can have these implants for months to years potentially and receive HIV treatment that way. And then vaccine. Unfortunately, we have not made a lot of progress in terms of vaccines, but hopefully that will be coming down the road soon. So all the good news, but here is something to take pause in, and that is a looming crisis. And I don't have to tell anybody on this call, because they're all nurses, they're all healthcare providers, and we know that right now we are in the midst of a crisis for our whole healthcare system with nursing shortages. And when we think about specifically the field of HIV and the number of clinicians who are knowledgeable and skilled in HIV care, really that is also a very stark future to think about. There was an article just published by several folks out of Duke, but one, Dr. Guillermo Ramos, is a former NYU faculty member, professor, who's now the dean at Duke, wrote this, was one of the co-authors of this, in terms of nurse practitioners filling the gap in the HIV workforce. And I think that is something that where we think about opportunities for us, what can nurses do? Really, we can serve as educators to educate about the importance of testing, the importance of treatment, and the opportunities for prevention. We can advocate for just and equal access. We can advocate for policies that support support the implementation or the full implementation of the National HIV Strategy. You can work to reduce stigma, both in your workplace and in your communities by breaking down those barriers. And you can engage both your colleagues as well as patients in who may be living with HIV or those at risk for HIV, and get them into that status neutral continuum. So in terms of where we are as nurses and where you are as nurses in the field, you have and we have our work cut out for us if we're going to get to that goal of reducing the number of new infections to reach the 2030 target. And so in summary, the HIV epidemic remains a global health issue. Advances in HIV treatment and prevention are making a difference, and clinicians need to adapt and expand their capacity to care for persons aging with HIV. Success of the National HIV Strategy requires a collaborative effort, and really nurses play an integral role in the HIV care continuum. So with that, I'm going to close and thank you. This is my contact information, and I think we have a few minutes for questions. Sorry, I went a little longer.
That's amazing. Dr. Kwong, thank you so much. I've certainly taken so much away this evening. I want to pause here. We do have some time for some questions if you want to either unmute or put your question in the chat, please.
I have a question.
Go ahead, Bobby.
Hi. So this is kind of a new treatment that I'm seeing a lot of press on lately is the stem cell treatment. I think I just saw an article last week that they now have up to 5 people who they think are cured, quote unquote.
Yes.
Because it's been, I
Yes.
think, a few years since they've actually taken their medication and they're still undetectable. So what do you think about that? I know the stem cell process is pretty dangerous and usually only reserved for people with like terminal illnesses. But do you think like if the technology advances enough to where stem cell becomes more safer and more common, do you think that's a possibility that could really help population living with HIV?
Yes, thank you for that question, and that's great. And yes, you are correct. Again, it was reported just last month, the 5th person who received a stem cell transplant. Again, these I think are very novel interventions. They're very, I think we're not at a point where it's scalable. It takes a long time. And, you know, when we think about 5 people, and we also then think about the 32 million people living with HIV, and we think about scalability, you know, I think it will be something that I know they're doing additional research to sort of find ways to sort of understand, you know, sort of the mechanisms and how they can take advantage of that to make that broader. But yes, you know, I think that those are very exciting cases to see. And I think more to come on that.
Great. Thank you. So another question in the chat is from Dr. Lim. If someone is on PrEP and they take it inconsistently or stopped taking it, would it increase viral resistance if the person later acquires HIV?
That is a great question. So it really depends on a couple of things. So there is something called event-driven dosing or 2-1-1 dosing, which is where individuals who may be at risk for HIV may not necessarily be at continuous risk, right? They still are engaging in sexual activity, but maybe once every 2 months or once every 3 months or, you know, once every 6 weeks. And they don't necessarily want to take a medication every day. They don't want to take PrEP every day. So there has been data and there have been studies that show that there is a way that you can take PrEP, specifically tenofovir, disoproxil fumarate, and emtricitabine in what's called a 2-1-1 method, where you take 2 doses, 2 to 24 hours before, and then a single pill daily for 2 additional days until you've had 2 sex-free days from that event. So that's somebody where, they're not taking it consistently, but in those situations, that's been effective. Now, where we see people who may develop drug resistance is if somebody is taking it inconsistently and they're not doing the 2-1-1 dosing, and they're taking less than 4 pills a week, and they acquire HIV during that period. Yes, there is the risk of potential for drug resistance, and that's why we advocate for frequent testing, about every 3 months, for people who are on PrEP to make sure that they don't have HIV, because if they do, we need to up their treatment options.
Great, thank you. And possibly our last question for the evening, how has the cost of HIV treatment improved over several decades? This question is from Nick Munn. And has there ever been significant problems with individuals diagnosed with HIV not being able to afford medication or treatment?
Yes. So HIV treatment cost, I think, it would be safe to say over the years, because of the economic inflation, et cetera, it's still quite expensive, but less so than, say, treatment for hepatitis C. But when we think about access to medication, so this still is an issue. I mean, there are federal programs available. There's something called the AIDS Drug Assistance Program, or ADAP, which provides federal assistance to people who may not be able to afford their medications. Most insurance, actually all insurance companies cover it. Medicaid, Medicare cover HIV treatment, but for some people where they don't have insurance or may have be underinsured, there are programs for people to make sure that they get treatment.
Great. And lastly, Marissa Contreras asks, will injections eventually be given at birth for the prevention of this virus?
That's a very interesting question. And I would say that in terms of, I think the question is more like, if there was a vaccine, could there be a vaccine that could be administered, as for an early age as a prevention? So potentially more to come. Who knows? I never thought we would even be talking about injectables, even 15 years ago. But here we are. So who knows? But that would be an amazing opportunity.
Wonderful questions, everyone. I want to sum up and wrap up for the evening. Thank you again, Dr. Jeffrey Kwong. It has been truly an honor. You've been so wonderful and gracious. Thank you for all who attended tonight. I think it's clear that we have a lot of work to do. We nurses are the future. We need to advocate, and we need to continue to educate and inspire, reduce stigma, and take better care of our patients and all of them. So thank you again for attending. You will be receiving a survey later this evening, and we encourage you to please share your feedback about this excellent program. Also, please join us for the next Myers event, which is Demystifying the Publishing Process. That program will be held online on April 4th at 6 p.m., and we hope to see you all there. Thank you again to Jeffrey Kwong and to everyone for being here with us tonight.
Thank you.